My name is Morshed, and I get the opportunity to talk to you about one of the most interesting and controversial topics in all of orthopedic trauma: the relative rarity of this injury and the high stakes due to the impact our treatment has on the viability of this important joint contribute to the emotion around this topic. I hope to summarize the evidence and what we know on this subject in order to provide some guidance to you when confronted with your next femoral neck fracture in a young patient. I have no potential conflicts of interest with respect to the content of this lecture. My full disclosure list is available on the AAOS website. We're going to start this discussion with anatomy, particularly the vascular anatomy of the femoral neck and head, because it seems to influence so much of what we believe should influence timing and method of reduction and fixation of these injuries. I will then show you that emergent treatment of these injuries is not necessary, and which other factors, some under our control and some not, affect outcomes. While optimal approach to management is not known, we will discuss some tactics and fixation methods that you may find useful and are certain to generate some interesting discussion in the live meeting and in years to come. These are high energy injuries, unlike their geriatric counterparts. Femoral neck fractures in young patients result from an axial loading and abduction as mechanisms of injury. In association with shaft fracture, frequently the more impressive and distracting injury is not all that uncommon. So we want to make sure that we are looking for a possible femoral neck fracture, not just before, but immediately after reducing and fixating femoral fractures. As you listen to the information I'm about to give you, I want you to think about how you would approach this patient that I met about 5 years ago. He was a 28-year-old software engineer, had a motorcycle collision. This was an isolated injury to his left hip. He's otherwise healthy, non-smoker, and no other major medical problems. You can see here a displaced vertical neck of femur fracture. And I want you to think about how you might approach this patient over the course of this lecture. We'll come back to it. Now then, let's start by discussing the vascular anatomy of the femoral neck and head. Anatomic investigations demonstrate the importance of the intercapsular retinacular branches of the medial circumflex femoral artery on the perfusion of the femoral head. The most common justification for emergent care of femoral neck fractures has been to rapidly reestablish the blood supply and thus decrease the risk of AVN and non-union when retinacular vessels remain intact but kinked or stretched due to injury and displacement. More recent anatomical studies have shed light on the importance of the medial and anterior neck vascularity afforded both by the inferior retinacular artery from the medial femoral circumflex, but also the ascending branch of the lateral femoral circumflex within the anterior retinaculum of Whitebrecht. The lateral perfusing nearly half of the anterior inferior femoral neck. This is critical information for us and for those performing an anterior intercapsular approach for reducing or attempting placement of a medial buttress plate where these structures may be jeopardized. In a meta-analysis of 18 studies of young patients with femoral neck fracture, with timing of fixation reported and a minimum of 1-year follow-up, no significant differences were noted in non-union or avascular necrosis rates by timing of reduction and fixation. There aren't many comparative studies that have compared early versus late fixation as defined by this 12-hour threshold, but those that have didn't find differences in non-union and avascular necrosis rates attributable to timing either. Of course, these were small studies, potentially underpowered to detect very small differences in complication rates. Moreover, several case series of patients treated after significant delays of weeks or even months reported rates of non-union and avascular necrosis and functional outcomes similar to studies just mentioned. And this finding has been interpreted as further refutation of an association between time to reduction and fixation and poor outcomes. So if not early fixation, as many of us were taught to honor as an undeniable tenet of proper treatment of these injuries, then what? Well, the literature has consistently identified other factors that are consistently and more robustly associated with the development of complications, and I will now review them with you. While the Garden classification may have some utility in determining treatment for geriatric hip fractures, it is the Powell's classification and its appreciation for the shear forces seen at the fracture site, depending on the verticality of the fracture, after repair, that correlates most strongly with non-union and fixation failure in this population. For all the anatomic reasons already discussed, degree of initial displacement, probably by way of the amount of soft tissue and vascular disruption, is highly correlated with complications. Similarly, the degree of posterior comminution correlates with poorer outcomes, probably by way of its association with likelihood of disruption of retinacular branches of the medial femoral circumflex artery. All the factors we have discussed thus far are out of the surgeon's hands. Now let's consider something that we have some control over, the quality of reduction. This has been strongly associated with good outcomes, more so than any other surgeon-controlled variable. The problem in understanding a causal relationship between quality of reduction and outcome is disentangling it from the confounding that comes from the severity of injury, i.e., the worse the fracture severity, the more difficult it is to obtain and maintain an anatomic reduction. Moreover, how good does the reduction have to be to obtain a good outcome? Is there a threshold? And can you judge this based purely on fluoroscopic or radiographic findings? These are highly contentious issues. Well, I was taught that the only way you can know is to perform an open reduction to see for yourself. Coming back to our patient case, that's what I did for our patient that I presented at the beginning of this talk. It was a comminuted Powell's 3 fracture, as I mentioned. I was very careful to avoid placement of retractors around the femoral neck to avoid injuring retinacular vessels. I used a combination of wires and joysticks and a pointed reduction clamp on the anterior neck to hold and compress across the fracture, and added a medial buttress plate to augment my screw fixation. After a decade of doing almost exclusively open reductions for femoral neck fractures and looking very honestly at my own results, I realized I wasn't doing any better than the unacceptably high rates of complication that I've already shown you in the extant literature. I was able to get together with colleagues at 11 other prominent level 1 trauma centers around the country in order to test this dogma that open reduction led to better outcomes. After extensive effort to control for confounding factors like injury severity and patient factors predictive of outcome, we found more than a 2-fold increase in the risk of reoperation, most commonly for non-union and avascular necrosis, amongst those patients undergoing an open reduction as compared to closed reduction. This was consistent with a systematic review that my group had published years before and really compelled me to question my practice. Now, I want to be really clear. These results don't support closed reduction for all cases and certainly don't suggest that an inadequate radiographic reduction should ever be accepted. Rather, it convinced me that when my radiographic reduction looks close to anatomic and orthogonal planes, that fracture may not do any better having an open reduction, and I may avoid complications by avoiding doing so. After treatment, are there other factors to look for that predict outcomes? Well, one to look for is, short of catastrophic failure of fixation, of course, is femoral neck shortening. Neck shortening of the femoral neck is not good for the hip joint health and function because it decreases abductor moment arm. thereby increasing joint reactive forces. It also is bothersome to patients in resulting in a limb length discrepancy. And there is good documentation in the literature that shortening of at least 5 millimeters is very common in your postoperative findings, occurring in up to 66% of subjects. Well, does this matter? Well, sure it does. There's good evidence to show that the degree of femoral neck shortening correlates closely with functional outcomes. In fact, it's been shown to be one of the strongest predictors of SF36 after controlling for other patient and injury factors. Well, if shortening is bad, then what predicts shortening? Is there anything we can do to stop it from happening? In addition to degree of initial displacement, it's been shown that angle stable fixation with a sliding hip screw and side plate, a construct that has been suggested as superior with respect to non-union rates, particularly within more vertical or Powell's 3 fractures, is actually associated with greater degrees of neck shortening. This, of course, got many to consider whether not just angle stable, but potentially length stable fixation could improve outcomes. That idea was snuffed out pretty quickly in a small but influential case series of patients with neck or femur fractures repaired with a proximal femoral locking plate, and confirmed the suspicion that many held that some degree of neck shortening is actually a necessary evil in achieving union. And this brings us to our latest experiment in fixation strategy for femoral neck fractures: implants that allow for controlled compression or settling across the femoral neck fracture. The two devices here are FDA approved for this indication, coupling angle stable fixation with mechanisms to achieve continuous compression without the risk of rotational displacement with implant insertion. Clearly, if these devices or any others, and you know there will be more, are to be the panacea they can't claim to be, comparative trials are needed to show their superiority to existing technologies. And with that cautionary note, let me return us to the case that got this whole discussion started. I saw our 28-year-old software engineer with a motorcycle accident in the latter part of the morning on the day of his presentation. And after no other injuries were found, I was able to arrange to get him to surgery early afternoon that same day. Mind you, if he had come into the hospital at 10 p.m. or later that evening, I would certainly have felt comfortable putting him into my trauma room to start the next morning with a fresh team and a fresh surgeon. Anyway, I performed an open reduction using a modified Smith-Peterson anterior approach to the hip. I already described some of the reduction techniques I used, and here are the final post-operative images. I was pretty satisfied with this. I judged the reduction to be anatomic by directly visualizing the fracture site and was happy with the spread of my screws and the reinforcement afforded by my medial buttress plate. So I made him toe touch weight bearing for 12 weeks as I typically do, fully anticipating union and a great outcome, right? Wrong. He came back at 3 months and I didn't have any reason to question his compliance, but in addition to some shortening of the femoral neck, he was falling into varus. Clearly, this wasn't working, and a CT a month later showed a non-union of the neck of femur. And for this, I performed a Powell's intertrochanteric osteotomy. And this got him to union and a pretty satisfactory functional level. I'm showing you 5-year follow-up because you need to follow these patients with these kinds of injuries for at least a few years to know that the joint is hanging in there and free of avascular necrosis. So I will leave you with this sort of successful case and outcome as a reminder of many of the learning objectives from this talk. Understand the anatomy, particularly the vascular anatomy of the femoral neck. I think its tenuous nature explains much of the risk of poor outcome after these injuries, be it non-union or avascular necrosis. While quality of reduction is probably the most important surgeon influence factor predicting outcome, Much of the dogma about emergency treatment and open reduction for every case should be questioned in light of literature published over the past few decades. Other factors that we know to be important, such as degree of shortening at union, may not be easily countered, nor should it be necessarily. At this point, we do not have a way of maintaining anatomic length without promoting non-union and hardware failure. Finally, while new approaches to fixation convey an understanding that these fractures need to experience some degree of compression without shear, we need to demand the highest possible quality of evidence prior to concluding that we are actually doing any better for our patients. Thank you very much for your attention.